welcome everyone to this evening's small animal referral webinar series installation. Today we have Aidan McAlinden, one of our amazing surgeons from Northern Ireland veterinary specialists. And he's going to talk to us about a breath of fresh air. And if you have any questions, please feel free to key them into the Q&A field. So somewhere on your screen is a button called Q&A. Press it and just text in the questions, and Aidan will go through them at the end of the session. We will send you attendance certificates so you can use it for your CPD requirements in due time. So give us a day or two. And the recorded webinar will be available on the CVS referrals webpage for the next 2 weeks. And with that, I'm going to hand over to Aidan. Go for it, Aidan.
Thank you very much, Renee, and for the introduction. As always, I feel Renee has set the bar very high there, so hopefully this doesn't disappoint. Yes, a breath of fresh air sounds very apt at the moment, and something we're all longing for as we wear masks in our daily lives. But yes, fundamentally, what I'm going to speak about over the next 50 to 60 minutes is brachycephalic obstructive airway syndrome, or I guess as it's more commonly known to us is in terms of BOAS. I've the pleasure of speaking to you tonight from the beautiful, albeit that a biased view, County Down countryside. This is our hospital here, Northern Ireland Veterinary Specialists. And for those of you who don't know us or where we're located, we're pretty much about halfway between Newry and Belfast, as I say, in County Down, Northern Ireland. So we're about 30 minutes outside Belfast city and about an hour from Dublin. And we receive referrals from right across the island of Ireland. At the end of the talk, if you bear with me for the full 60 minutes, I have a short little video clip that give you a little peek behind the scenes at our hospital. As you can see, the kind of the aerial shot here of the practice, but I'll give you a little behind the scenes look and share a little bit about our values here at the practice and indeed our mission. So without further ado, we'll get started. And I guess what I want to cover over the course of the webinar is a little bit, first of all, about the evolution of BOAS, and I guess a little bit about how our understanding of this reasonably complex condition has evolved over the years, and kind of where I sort of reconcile things and where I am at with the condition at the moment. And I'll spend a little bit of time talking about that. There's not a huge surgical focus on this talk. I'll talk certainly quite a bit about patient assessment. I will mention surgical treatment and what I typically do for these patients after that, and how that has evolved over the years. And then I'll finish off talking a bit about how we might deal with an acute episode of dyspnea of the upper respiratory tract, or an obstructive crisis, which can happen either as these patients present to us. You know, a lot of them do present as emergencies in the first instance and require stabilization before they ever get to the point of having an assessment and surgery. But of course, it can also happen post-operatively after they have had surgery. So I'll talk a little bit about that, and that'll pave the way off to finishing off on a kind of practical note, where I'll share with you a few little sort of tips and tricks in terms of how to do a temporary tracheostomy. Again, which may be needed in the acute kind of crisis situation when a patient presents as an emergency, or again, as it's been shown, is needed occasionally post-operatively. Next month's webinar offering from NiVS is going to be by one of our head nurses, Shirley Bell, who's going to actually talk about nursing and the post-operative management of BOAS patients. So hopefully that'll pave the way for Shirley, who's got really significant experience in nursing these kind of patients. And I'm going to leave that aspect for her to discuss in a lot more detail next month. So to start off, what is brachycephalia and what's our understanding of it? Well, I guess ultimately it's a form of chondrodysplasia, dysplasia, where we get this early ankylosis of the splanchno-cranium. And ultimately that gives us this sort of rostral to caudal foreshortening of the skull. And of course, all the soft tissue structures that always sat within the skull are still there, but they're compressed within that much smaller space. And I came across this picture about 10 years ago. This is with credit to the Natural History Museum in Bern, Switzerland. And I just thought it was absolutely telling in terms of how the selection pressure in terms of our breeding over the years has changed the conformation of the skull of brachycephalic dogs. So over here on our extreme left, we can see the skull of an English or British bulldog around the early 1900s. And you can see that actually there was a reasonable nasal cavity and indeed a muzzle that was present in these dogs. Of course, we had that overshot lower jaw, so these dogs were still brachycephalic by definition, but certainly very, very different in appearance to what they looked like in the kind of the 60s. And then again, today with this really domed skull that almost overhangs the residual nasal cavity and a significantly more overshot lower jaw. And this is certainly what we're faced with more and more often in the clinic. And I just think it's really dramatic what that selection pressure for a certain aesthetic has created. And this subject is really pertinent, and it is just unbelievable in terms of the popularity of these breeds. And there's been an absolutely exponential rise in numbers. And some of these figures really sort of beg belief. If we look over here at the French Bulldog, certainly the most popular brachycephalic breed. And I understand why they are as popular as they are. You know, these dogs have tremendous temperaments, really lovable dogs. And certainly all of them as pups, as we see here, are incredibly endearing and attractive. But there's been a 3,000% increase in popularity of the French Bulldog. Now, that hasn't been seen to anywhere near the same extent in the Pug and the English Bulldog, but it's certainly going in the same direction with kind of 200 and 100% increases respectively. And putting some numbers on that, these are actual official Kennel Club, so UK Kennel Club breed registration statistics. And if we go down to the bottom here and look at the French Bulldog, first of all, you can see if we go back to 2004, around the time I qualified, there were 350 French Bulldogs registered in the UK that year. If we fast forward on then 12 years to 2016, we have over 21,000 of those dogs registered. And bear in mind, this is only really the tip of the iceberg, because there's a lot of dogs out there, of course, that are not Kennel Club registered. And because of the popularity of these breeds, of course, there's I guess a great incentive, if you want, for breeding these dogs from a financial perspective. And they certainly are fetching very, very high values as pups. I guess the other interesting aspect in terms of popularity was in terms of breed popularity. And if we look back to 2017, the top 20 breeds in the UK, and the Labrador Retriever was #1 on that list and had been for many, many, many years. And the French Bulldog appeared up sort of behind it in second place. But 2018, it actually knocked the Labrador Retriever off the top spot and took over the most popular breed according to Kennel Club breed registration stats. Now, I think it would be really difficult to give a presentation on BOAS and probably irresponsible to do so and not mention some of the welfare issues that are associated with this breed. And I'll draw your attention to this paper here that was published recently. And this is a paper that's free to download, and anyone with certainly an interest in this topic, I would recommend reading it. And it's a review article that came from Australia, and it was written by groups of veterinarians that were who typically manage brachycephalic dogs on a routine basis as part of their caseload. And I guess it documents that sort of widespread sort of belief that there is a strong link between this sort of extreme brachycephalic conformation and phenotype that we now see and the presence of chronic disease. that ultimately compromises the welfare of these patients. They did this by actually looking at insurance claims that were made against a whole host of different conditions, and they compared the number of insurance claims, or the prevalence of them, in both brachycephalic breeds and non-brachycephalic breeds. So the brachycephalics here are in the darker blue color, and the non-brachycephalics in the light blue. And you can see right down along the left-hand side here, everything from BOAS to orthopedic conditions, skin conditions, gastrointestinal conditions, and ocular conditions. The brachycephalic breeds far outweighed the non-brachycephalics in terms of number of claims made. And I guess nowhere was that more evident than in the case of BOAS, which would be, of course, expected. So those welfare issues are out there, and that's certainly something I feel very strongly about. Undoubtedly, BOAS is the one that there has been the most, I guess, press, and the condition that has been highlighted most by the veterinary profession. And we've taken a very strong stance in terms of the welfare issues that are there. And of course, it's not just breathing issues these dogs suffer, but there's a whole host of other aspects that are affected in terms of their respiration. So we know they suffer sleep disorders, much like sleep apnea, that occurs in typically middle-aged and older men that are overweight. They suffer terribly in terms of exercise intolerance. And because the respiratory tract is so involved with particularly the canine ability to thermoregulate, these dogs suffer with heat stress. And of course, there's often this seasonal presentation of BOAS patients, where we typically see the peak of them in the warmer summer months. Of course, very closely linked to the respiratory disease is the gastrointestinal disease. And I'm going to come back to that a little bit later on, because there's a real strong sort of correlation and interlinking of those two conditions. And then there's the host of other, both skin, ocular, neurologic, and indeed orthopedic problems in these patients, compounded really by the issues they have with dystocia. So really their inability to undertake normal, everyday activities that often necessitates medical or surgical intervention at a very early stage in life really does affect the overall quality of life for the more severely affected patients with this condition. And I certainly would like to think that if I was given this presentation in 10 years from now, the focus wouldn't necessarily be on the surgical treatment for BOAS, but hopefully saying that the prevalence of that condition is a lot less than what it is now, and we've managed to I guess change that genetic selection pressure and outbreed some of these issues. And I think it'll be a big challenge, but that's what we're up against. One of the other big factors that I think comes into this from a kind of ethical stroke welfare point of view is the owner's perception of what is normal for some of these breeds. And it's been well documented in a number of different studies that estimations of up around 50 to 60% of owners of brachycephalic breeds fail to actually recognize symptoms and feel it's just part and parcel of being that breed. And that causes real problems for us. And I guess I would also pose it there, in terms of, is there also a veterinary view, is our view of these patients skewed? Do we accept greater severity of symptoms in these dogs than we might do in other breeds? I'm not saying that's the case by any means, but it's something I think I certainly reflect on and think about. The overall sort of consequence of this is that it's typically the much more extreme cases that then are presented to us. And disease is often very advanced by the time we're faced with treating them. So some of these patients are really some of the most challenging patients that we treat in the clinic. And there's a lot riding these patients when we take them in. And certainly it can negatively affect the outcome. We sometimes we're up against it a lot of times by the time we're presented with these patients in terms of trying to restore a level of normal functionality and improve their quality of life. So this is one such patient. This is one of our very early patients here at Northern Ireland Veterinary Specialists that presented for assessment of BOAS. This patient is 3 years old and was sent for a somewhat semi-elective assessment of his airway because there was a suspicion that he was suffering with BOAS. Patient had about a 30-minute journey to the practice on a relatively warm day, and the only stress so far is actually being taken away from his owner and brought into the hospital. And we'll just let you see him here. Sorry, the video was just cut at the end. You may just have heard me over saying there, just let's get the oxygen, which was getting set up in the background. So this poor dog, you can hear that continuous inspiratory stertor. He's collapsed. He's unable to stand any longer. You can see he's been regurgitating this white frothy foam. His head and neck is outstretched. His elbows are abducted, all with this so-called air hunger, really desperately trying to get air into and past that upper respiratory tract obstruction. And you can imagine these cases are really challenging to, number one, stabilize, and number two, then operate on and return that functionality. So what are the primary anatomical abnormalities that we get of the soft tissues then in these patients? Well, I guess the first one that we are all very aware of are the presence of stenotic nares. So this is this kind of narrowing of the nostrils. The nostrils are normally this little sort of comma shape, and we can see them narrow into these vertical slit-like openings. Now, this patient here would have mild nares stenosis, and we know that the severity of the nares stenosis is predictive of the overall severity of their BOAS condition. And so very easy to recognize on physical examination and something that's evident from early on in life. The next aspect we have is elongation of the soft palate. So this is a picture here taken looking into the oropharynx. We can see the epiglottis, and we can see the tonsillar crypts on either side, and the soft palate sort of cycling down and sitting on top of the epiglottis. We can't see the larynx in this particular patient because of that elongated soft palate being aspirated in towards the laryngeal region. In a normal dorsecephalic breed here, when we put some retraction on the tongue, we'd be expecting to see the larynx. One of the landmarks that we can use here to determine whether a palate is elongated or not, rather than just a subjective assessment, is to draw an imaginary line from the caudal fornix of one tonsil across to the corresponding area on the contralateral tonsil. And if the palate extends beyond or caudal to that line, then it's deemed elongated. We can also then see some secondary degree of laryngeal collapse. So here we have everted laryngeal saccules. So this little tongue depressor is just sitting on the epiglottis. And we can see these saccules here that normally actually are sitting away from the airway, rostral to the vocal cords, but they've been sucked sort of inside out, much like you put in your hand in your pockets and pulling out the lining of your pocket, and they float around in the airway and cause obstruction. And then, so those are the congenital abnormalities that patients tend to be born with, but then they'll get these sort of secondary changes that happen over time. So the eversion of the saccules is a slightly better example here, as we described just now. We can also get a lot of hypertrophy of the surrounding mucosa. So this can be, for example, the aryepiglottic folds that lie either side of the epiglottis can become hypertrophied and obscure and obstruct the airway. We can also get tonsillar hyperplasia. And indeed, then we can just get functional collapse of the airway. So here in this patient on the right, we've got the cuneiform processes have effectively folded in medially and are almost touching on midline. You can see the saccules are also everted in this patient as well in the ventral aspect. And this is what we would deem grade 2 laryngeal collapse. This patient on the left is progressing closer towards grade 3 laryngeal collapse, where the cuneiform processes actually get to the point of overlapping on midline. This patient's actually had a staphylectomy. That's why it's a little bit easier to see the larynx here, and I'll talk more about that in a little while. So these are secondary changes that occur. And certainly whenever I graduated, I was very much of the understanding that these were late changes that happened later on in life and can sometimes be responsible for the deterioration of these patients when they get into middle or older age. And whilst that can be true, we know that's not necessarily always the case. And this was a really nice paper here that was published in the Journal of Small Animal Practice by former colleagues at UCD, Jonathan Pink, Ronan Doyle, and Professor Bellinger. And they documented laryngeal collapse in a series of 7 brachycephalic puppies that had presented for airway assessment and treatment. And these puppies were only between 4.5 and 6 months of age. And interestingly, they had quite advanced collapse. So 2 out of the 7 had what they call stage 1 or grade 1 collapse. 4 of them had stage 2, and 1 dog had already grade 3 laryngeal collapse. So that's where we get that overlapping of the cuneiform processes on midline. And you can see the outcomes here were actually pretty bad. The dog with stage 3 laryngeal collapse and one of the other dogs with grade 2 collapse actually died over the postoperative period. So the big take-home message from this paper that really changed the way I kind of looked at these patients was that, immature brachycephalic dogs that are showing clinical signs of BOAS should undergo early and proactive assessment and ideally intervene before they develop these early secondary changes that are somewhat irreversible. The other big thing I guess I've learned as time has went on and so on, and I guess part of this has been through our availability of advanced imaging within veterinary medicine. But that initial view of kind of the stenotic nerve as an elongated soft palate leading to secondary laryngeal collapse was really oversimplified. And I remember so clearly almost memorizing off those abnormalities for final exams and so on. But it's really only the tip of the iceberg in these patients. And we know they have multiple levels of obstruction. And we really need to factor that in terms of being realistic in terms of what we can achieve with surgical intervention, and also thinking about what we can actually do for these patients. So unlike ourselves, dogs, we have an empty nasal vestibule. There's nothing inside our nostril, but dogs have this very large, voluminous nasal wing, which merges onto the alar fold, as we can see here. And that voluminous body then presses against the septum on midline. And it occupies most of what we call the nasal vestibule that sits within sort of a 0.5 centimeter to 1 centimeter deep within the nasal cavity. And that's also compressed. And we need to factor that in when we're doing rhinoplasty. And I'll come back to that later on. We talked earlier on about the fact that when you look at that skull from the early 1900s through to today, you can see that gradual compression and reduction in size. But we said that all of the soft tissues still sit within there. And one of the kind of tissues that are in there are the nasal turbinates. And ultimately, they have nowhere to go in these patients. So what they start to do is they grow down in a caudal direction into the nasopharynx, as you can see here. So this is a sagittal section on a CT scan. This image is from Uttering's paper that described laser-assisted turbinectomy, and it very beautifully demonstrated these turbinates that sit within the nasopharynx, and also those that grow rostrally along the ventral nasal meatus. So these are known as rostral and caudal aberrant conchae. And you can see these cause quite a significant amount of obstruction to the nasal passageway. This is on the right-hand side, a transverse section taken at the level of the nasopharynx, and you can see these turbinates again passing through the choanae and into the nasopharynx. And this is what from the same paper, what they look like on endoscopic view. So on the left here, we've got a flexible endoscope. It's passed into the oral cavity and then retroflexed around the caudal edge of the soft palate. And you can see then these aberrant conchae effectively growing out through the choanae and completely obstructing the nasopharynx at that level. And on the right here, we've got the nasal cavity with a rhinoscope in place. We can see the normal turbinates here, but down here, all this crowding are these rostral aberrant conchae that are completely obstructing and blocking that ventral nasal meatus to airflow. So these dogs really struggle to breathe through their nose and are often forced to try and breathe through their mouth, but of course they struggle with that as well. The other big realization was that these patients also have pharyngeal stenosis. So the soft palate isn't just elongated, but it's massively thickened as well. And this is potentially something that also progresses as a secondary change over time, because we know there are muscles that run through the soft palate, so-called palatinus muscles, and they constantly try to contract to shorten the palate and create some air and space at the caudal edge. And of course, that constant contraction leads to hypertrophy as well. And you can see these dogs also have macroglossia, have big tongues, as we know. Anyone's anesthetized one of them will know that. And if you look at the top radiograph here, it's a lateral cervical radiograph. We can see in a Brachycephalic breed, we can see the soft palate highlighted here. And we've got these radiolucent air opacities dorsal to it. So in other words, that's the nasopharynx. And we can see the radiolucent opacity ventral to it, which is the oropharynx, leading back here to the larynx. On the contrary, if we look at a brachycephalic breed, we can see this massively thickened palate, see a big tongue sitting here as well, and this effectively compresses right across the pharynx. So we've got really significant obstruction through there. And of course, as these patients age, they tend to carry a lot of weight around their neck, and therefore obesity can tend to exacerbate this effect. And there's a nice study that looked at the girth around the neck versus as a ratio, if you want, to the circumference around the waist. And certainly that ratio is predictive of BOAS severity in English bulldogs, at least. Again, this is a recent CT that we did here at the hospital for a patient actually presented for middle ear effusion, so it wasn't really here for its airway. But again, you can see this sagittal section, and you can see this extremely narrowed and compressed nasopharynx before we get here to the larynx. So this is the hyoid apparatus just here, and we can see this really compressed nasopharynx. And of course, they have tracheal abnormalities as well. Some people would see these as part of BOAS system or syndrome, sorry. Others as a separate entity. It does have a slightly different developmental etiology. But we make a diagnosis of tracheal hypoplasia when the ratio of the trachea to the thoracic inlet is less than 0.1. And we know that a lot of these brachycephalic dogs certainly suffer with this as well. Of course, this further compounds the upper airway compromise and so on. But interestingly, in most studies, it doesn't seem to affect overall prognosis. So its presence or absence doesn't seem to affect that. And that can carry on down into the bronchus as well. So again, we can see a degree of just like laryngeal collapse, we can see bronchial collapse as well. And certainly there's a correlation between the severity of the laryngeal collapse and the severity of the bronchial collapse. It seems to have this tendency to affect the left mainstem bronchus a little bit more than the right. The pug is one of the breeds that's most predisposed to this. And given that pugs tend to have a predisposition to lung lobe torsion affecting the left cranial lung lobe, there is that hypothesis out there that actually this bronchial collapse predisposes to that condition in that breed. This picture on the left here, I'm sure most of you treating brachycephalic dogs will have witnessed this. And this is a patient that has spontaneously regurgitated, and in this case, some of the stomach contents. And interestingly, when you speak to clients who present brachycephalic patients to us for whether it be BOAS assessment or for orthopedic or spinal problems, they don't always necessarily disclose this in the history. And again, it's back to that perception of what is normal. But when you specifically ask the question, does your pet regurgitate or vomit, they'll often disclose then actually they do. And sometimes this could be a daily occurrence, and they don't necessarily see that as significant. Or be very surprised to see an owner of a Labrador, for example, who wouldn't present their pet for that. So certainly, very, very common symptom. And there was a paper that came from the private practice in Paris, Frégy, that sees a huge number of French bulldogs, and they documented the prevalence of concurrent gastrointestinal tract lesions in a series of 73 brachycephalic dogs that all presented to them for assessment of BOAS. So they systematically asked questions about the presence of gastrointestinal signs in the history, and they did upper gastrointestinal endoscopy in all of these dogs and took gastric and intestinal biopsies. So a very systematic and comprehensive upper GI workup at the same time as they're having their BOAS workup and surgery. And they found a very high prevalence of this in the order of over 90% of patients having concurrent GI issues. And these ranged from, as you can see over here on the right, things such as linear striations here with inflammatory change in the distal esophagus, indicative of a degree of cardial reflux and esophagitis. A more severe manifestation of that over here, where we have overt ulceration and certainly the risk of stricture formation in this patient. And another really common abnormality here that we see a lot, which is this esophageal deviation or redundancy. So you get this kind of outpouching of the esophagus just before it enters the cardia into the stomach, just cranial effectively to the lower esophageal sphincter. And again, this is just this whole sort of foreshortening in the whole length of these patients. You know, if you think of the degree of scoliosis and kyphosis these patients have, they're fundamentally foreshortened. And the esophagus is effectively too long for the chest cavity, and you get this sort of flaccidity to it and GI signs as a result. And we know there's a strong correlation between the severity of the respiratory signs and the severity of the gastrointestinal signs. One of the other more severe gastrointestinal abnormalities that we can get is hiatal herniation. This CT sequence here is from a good friend of mine, Jerry O'Riordan, who's a surgeon based down in Cork. This is a French bulldog that he recently treated for both BOAS and hiatal hernia, and he did a CT in this case here. We can see the chest, and we can see this sliding hiatal hernia here, where we have part of the cardia of the stomach moving forward and sliding into the thoracic cavity, and of course causing associated clinical signs. And this is the sort of diagnosis that would require surgical intervention typically to resolve. There was a follow-up paper to the last one that I spoke about there. So the first study documented the prevalence of concurrent GI issues in French bulldogs presenting for BOAS. And then in a second cohort of dogs, they systematically medically treated those gastrointestinal abnormalities. Now, a lot of the times that was with gastric protectants, antacids, proton pump inhibitors, sometimes prokinetics, sometimes steroids if there's inflammatory bowel disease there. And they found that there was a significant improvement in overall respiratory outcomes when those concurrent GI issues were, number one, identified, and number two, treated. And really interestingly, there seemed to be both short and long-term resolution of the gastrointestinal signs in excess of 80% of the cases. And that's even when that medical therapy was weaned off in the longer time. The patients that had the concurrent medical therapy also had a lower overall complication rate. And the other really interesting thing is that the gastrointestinal signs tended to improve even in those dogs that had just their airway treated. And to me, that makes sense, because if you think about the way these brachycephalic dogs are breathing, as you saw in the earlier video there of the American bulldog, they effectively are creating quite a deal of negative inspiratory pressure in the upper airway. And that is predisposing them to some degree of cardial reflux and that esophagitis and so on. So if we can reduce the amount of negative pressure in the upper airway, then often we can actually reduce the amount of gastroesophageal reflux and reduce the severity of those symptoms. So for me, things have evolved a little bit that if patients come in to see me for the sort of semi-elective, if you want, assessment of BOAS, if there are negligible or very mild gastrointestinal signs, I generally concentrate on their upper airway problems and treat those surgically with an expectation that their gastrointestinal signs should improve. But if they come in, on the other hand, with very severe respiratory or gastrointestinal signs, sort of on a par with the severity of their respiratory signs, then they'll have a specific workup for that at the same time and targeted treatment of that to hopefully improve their overall outcome. So I guess a really common query we get here at NiVS, and it links back to what I was saying earlier on about the very early development of laryngeal collapse, is when should we think about actually assessing these patients? You know, so they present into the clinic for potentially neutering or vaccinations or other medical issues, and we see evidence that there's potentially some upper respiratory tract compromise, are those cases that we should be then proactively looking at? And I think largely speaking, yes, and the sooner the better. But one of the things that can help us a little bit with that is some of the functional assessment, first of all. And this grading scheme here for BOAS, which was developed by the University of Cambridge, is a very nice way to grade these patients from grade 0, so sort of non-affected if you want, through to grade 3, with the most severely affected patients. And effectively this is an exercise tolerance test. So we take our BOAS patient and we first of all listen to them, and we listen for the presence of respiratory noise, and that could either be not audible or audible. When we talk about mild respiratory noise, that'd be stertors and stridors that we pick up with the use of a stethoscope to hear it. So a stethoscope placed over the upper airway, and we need that to actually hear the high-pitched noise, if you want, due to that compressed and compromised airway. Moderate signs would be typically intermittent, but we can hear it without the use of a stethoscope. And then severe respiratory noise would be that which is pretty constant. And again, you can hear it without a stethoscope, much like we saw in the earlier video. So we can look at that respiratory noise. We can also look for the presence of respiratory effort. And again, that's whether the abdominal muscles are being recruited and the diaphragm is being recruited to assist with breathing in these patients. And again, that's graded from either not present through to mild, moderate, or severe. And then, of course, we look for the presence of severe signs such as dyspnea, cyanosis, or syncopal events. And we do all this at rest, and then we do a 3-minute exercise test. And this is where we get these patients to sort of at a fast walk or trot. The aim is for 4 to 5 miles per hour in terms of speed. And we do that continuously for 3 months, 3 months, that'd be aspiration, for 3 minutes. And then we repeat these observations. And then depending on where they sit, we can drop them into this table and grade patients. And generally speaking, if patients are grade 0 or 1, we would call them typically BOAS negative. And those patients, we would just recommend a follow-up examination after 6 to 12 months to see if things have changed, to see if we've got any of those secondary changes that are causing deterioration. On the patients that are grade 2 or 3, then we would say, okay, we want to do an upper airway assessment under anesthesia, characterize the abnormalities that are there, and likely treat those patients. So this really helps us have a more objective assessment of these patients, both pre-operatively, and it also helps us to assess these patients post-operatively after some form of intervention. There's something I think we should be doing, and it's something we can very easily do in the clinic. And if we're getting patients that are falling into grade 2 or grade 3, then my answer to those would be yes, regardless of how early on in life it is, those are patients that we should assess. There are other functional tests out there at the minute as well, such as the 6-minute walk test. And this is where we set a timer and we walk the patient for 6 minutes, and we measure how far they can walk in that time. And there are cutoffs now published in terms of what would be expected for certain breeds. And likewise, we can then do a 1,000-meter walk test, where we walk these patients for a kilometer effectively, and we measure how long it takes them to do that, if it's possible for them to actually complete those tests. And certainly I know across Europe, particularly in Germany and so on, some of the breed societies are using these functional tests to help identify patients that are suitable for breeding or not, as the case might be. So once we've done that sort of functional grading and we've put a patient into then grade 2 or grade 3, and we need to take it on to the next stage. So how do we manage these patients surgically? And here we've one such patient just getting ready for the upper airway assessment and surgery now. As I mentioned at the start of the presentation, I'm not going to talk now a lot about the pre-anesthetic management or stabilization of these patients at this stage, because Shirley Bell is going to do a great job on that next month. I'll talk more now about how we actually assess these anatomical abnormalities. So quite hard to actually talk over that little this little pug. As this beautiful little dog was referred for that assessment, she actually fitted grade 3 on the assessment scale there, functional grading. This is her at rest. So you can hear that constant inspiratory noise without a stethoscope, of course. I couldn't even talk over her. You can see the abdominal efforts are being recruited. There's no drugs on board at this point, no pre-medication yet. This is her baseline. So the first thing we'll do is we'll have IV access in this patient. You can see she's being pre-oxygenated there, and then we'll go ahead and do the upper airway assessment. You can see right away she had severe neres or stenotic neres, and that's very easy to diagnose right away. Then we'll retract the tongue very gently, use a laryngoscope, and we'll look into the oropharynx and see whether the palate is elongated. As we described earlier on, anything that extends beyond that line that goes from the caudal fornix of one tonsil to the other is deemed elongated. And just as visual reference, you can see here's the brachycephalic on the left and here's the non-brachycephalic on the right. So quite a stark contrasting difference. So we'll document what those abnormalities are first of all. And then we'll generally, at the same time as assessment, try to treat these patients. And that's something I would really say, that if we're strongly suspicious of BOAS, it's much more preferable really to do the assessment at the same time we can subsequently treat these patients. Because even just temporarily anesthetizing them and maybe intubating them just to do an airway assessment, we can find ourselves in trouble then trying to get these patients extubated and recovered. So it's much better to be able to go ahead and do the surgery. So here's a patient in terms of how we position them in theatre. You can see we're using tape here to maximally open the mouth as much as possible. So these are connected, the maxilla is connected here to an A-frame, or you can use 2 drip stands either side of the patient, and the mandible is tipped down to the operating table with the chin resting on a sandbag or a foam wedge. And then historically what was described as a standard staphylectomy was then effectively a straight cut from the caudal fornix of the tonsil on one side straight across to the other side, often using some form of electrocautery to either cut or to coagulate the tissue and any bleeding vessels as we go across and ensure hemostasis. And then careful apposition of the nasopharyngeal mucosa to the oral mucosa in a little continuous suture pattern. And when I started doing airway surgery and so on, this is exactly what they look like at the end of that surgery. So you can see there's certainly an improvement from what we saw at the beginning, that you can now start to see the larynx, and it met that criteria in terms of being at the level of the caudal fornix of the tonsil. I guess the big change that happened in terms of the literature was back just over 10 years ago, when Findy and Gilles Dupré described the folding flap palatoplasty. They published this in the European Journal of Companion Animal Practice, and they documented it as a safe and efficient technique. And this was really on the realization that the palate is not just elongated, but thickened as well. And I'm not going to go into this in a huge amount of detail, but what they effectively were doing here is making this arch-shaped incision through the oral mucosa. And this would be at a point of where you would take the caudal edge of the palate, fold it rostrally, and where it touches the oral mucosa is where we start that plane of dissection. And that dissection plane will go through both the mucosa, the submucosa, and the palatinus muscles, so right up to the level of the nasopharyngeal mucosa on the opposite side. So think about you're kind of excavating out most of the thickness of the palate. A really interesting observation for me in these cases was that when I started doing these, is when you folded the caudal edge of the palate rostrally to where it touched effectively the roof of the mouth again, it was almost always at that junction of the pigmented and non-pigmented mucosa. That became fairly sort of standardized, and that's been observed by others as well. So then that tissue is effectively excavated, it's then resected, and the free edge of the mucosa is then brought rostrally and sutured then to your incision. And that's your folding flap palatoplasty. This is the kind of one example from their paper, and it just shows you the sheer thickness of some of these palates and the hypertrophy of that palatinus muscle that's in there. The results are really good. I mean, here, if we look at on the left, these bar charts, we've got patients that are on the far left here in the pre-operative period, then immediately post-op, and then over the follow-up period. Now, the blues are patients that were deemed in this study to be mildly affected, grade 1. The reds were moderately affected, and the greens were severely affected. Now, it's no great surprise that in the pre-operative period, most of the patients being selected and going forward for surgery were in the severely affected group. But in the immediate post-operative period, most of them moved to the left. So they moved down to either being mildly or moderately affected. So I think it's really important just to stop and say that we are not making these dogs normal by any means, but we're significantly improving them to a point of where they may still have moderate signs. But that seemed to be sustained in the longer term follow-up. This is about 6-month follow-up, I believe, here. And the pie chart here on the right demonstrates how quickly these dogs improved. So the blue here is the immediately sort of improved. And that was a big change for me here in this, in that the symptoms seem to be relieved very quickly after this surgery. And certainly in 3/4 of the patients, if you add in this sort of purple segment here, were improved within the first couple of weeks of surgery. And I found that really compelling in terms of starting to do that surgery. And I did it then for many years, particularly in the much bigger brachycephalics like the English bulldogs, the larger French bulldogs and so on. It can sometimes be a little bit more challenging to do in small pugs, cavaliers, and so on. I guess having reflected a lot in terms of what I was achieving and what I was doing, because the surgery is a bit more involved, there's more tissue handling, it takes a little bit longer to do, and so on. And I found, having reflected and thought about that quite a bit, that actually you can achieve the same thing by effectively, instead of making a straight cut across with your staphylectomy, in just terms of making a much more arch-shaped incision and bringing that resection much more rostral. So much more aggressive with the amount of tissue that we're taking away. And this is one example of that. So you're taking full thickness, both of the mucosa on the oral side, all the palatinous muscle and the submucosa, and the mucosa on the nasopharyngeal side. And there's enough redundant mucosa here to get a nice appositional closure all the way across. And I actually spoke recently to Gilles Lepre, who published the folding flap palatoplasty, and I think we're in agreement that if you were to actually do a CT scan of these patients and the folding flap palatoplasty patients post-operatively, you would see very little difference in terms of dimensions of palate that remains. And again, we see the surgery is relatively fast, and we see the immediate improvement with these patients as well. So this is just a little video here that shows you the next stage of the surgery, which is the laryngeal saccule resection. And this dog doesn't have particularly big saccules, but you can see they are everted into the ventral aspect of the rhemoglottis here. This is a patient here that has had that, if you want, modified staphylectomy that I've just described to you, that sort of arch-shaped cut, taking the full thickness of the palate away. And certainly when I look back on the palates that I operated on at the very beginning of my career, I can certainly appreciate that it was nowhere near as aggressive as this in terms of how much was taken away. So what we do here is, typically in most patients, we need to do a temporary extubation to access the saccules. It's very difficult to work around the ET tube, so we have propofol attached and ready to administer again if we need to. These are little Reynolds scissors, very nice for this, and we want to just incise along the base of the saccule without damaging the vocal cord that's caudal to it. We do that on one side, and then we move across to the other side. This is a patient from actually some time ago, one of the patients that was managed at Davies Veterinary Specialist during my time there. And that's the saccule out. I should say, just before I mention rhinoplasty, at the very end of that surgery, what I do now is we re-intubate the patient and then proceed with the rhinoplasty. But what I've started doing now is soaking some sterile swabs in iced saline, and that allows us then to sit that into the rhemoglottis against the surgical site where the saccules were removed, and then wrap it over the dorsal aspect of the tube so that it sits in contact with the palate. So then we can close the mouth down, and these patients then are sitting and effectively having the oropharynx ice packed whilst we go on with the third stage of the surgery here, which is the rhinoplasty. I tend to use just a very simple vertical wedge resection. And I just want to emphasize one point here, which again has come with the sort of the benefits of reflecting on in terms of how my surgical technique has evolved over time. This patient on the left is one from the early days of my residency, when I really just hadn't appreciated how big that ALR body was. So on first impressions, it looks like, yeah, you've done a reasonable job here, maybe a little bit better on the right than the left, in that the nostrils look wider than what they were. But if we travel in a little bit further into the vestibule, you can see this large volume of tissue still here, and the vestibule is still compromised. So I think this is more of a cosmetic rhinoplasty than a functional one, and I wouldn't be happy to accept this at the moment. This is kind of more what we're after here. So we can see the side that has been operated on, and we take out a large wedge. And to give a context here, in this little pug, I would have went the full depth of a number 11 blade into the alar body with that wedge that I'm taking out. And that allows that then medial wall of the alar body to be, if you want, rotated out laterally, and really to open up both the vestibule and the nasal cavity as well. And then we try to replicate the same situation on the contralateral nose. So much more extreme in terms of the amount of tissue we take away. And that's it in terms of the surgery. The next stage then really, I guess, is this recovery period, which, as I mentioned earlier on, can sometimes be the time whenever it becomes really challenging with these patients, because they have been intubated for a period of time. They kind of have a very, very compromised airway. As you know, there might be a little bit of post-operative swelling. I think that's where the ice packing really helps these patients. But we've got to now get them extubated. And I think doing this very carefully, very slowly, and bringing them around in a really controlled way is paramount. So we want to have them supplemented with oxygen the whole time they're recovering. If these patients start to panic on recovery and get worked up and start to hyperventilate, they're going to get a lot of secondary dynamic collapse, much like those patients that come in as an emergency pre-operatively. It's often that panting and so on that exacerbates the problem. So anticipating that, potentially giving them some sedation as they start to come round from surgery. That might be repeating your pre-medication of, potentially something like promazine or dexmedetomidine, potentially titrating that to effect to get a nice calm and controlled recovery is important. Secure IV access is more an issue with the pre-operative patients, because obviously when they're recovering from surgery, you'll have that. These patients often can be hyperthermic rather than hypothermic, and we've got to think about that, because if they're hyperthermic because of the work they put into breathing, particularly if they presented as an acute crisis in the first place, often those patients need some degree of cooling to help them be more oxygen responsive and to stabilize things. And this is certainly one of those instances when I will sometimes use a one-off dose of an anti-inflammatory steroid, so something like a 0.1 milligram per kilogram dose of dexamethasone IV to get that, I guess, early and significant anti-inflammatory effect and to help prevent and control any edema or swelling that might be presenting in the airway. And generally speaking, for most patients, that resolves the problem, and we can get them recovered and get them back to hopefully better than their baseline pretty quickly in the post-operative period. Some patients don't, and things we lose control of the airway a little bit, and generally speaking, we just have to re-intubate them. So we normally recover these patients in theatre where they're still in that kind of stand position. We've got good lighting, we have a laryngoscope and blades there, and fresh ET tubes, so we can very easily re-intubate these patients, and generally everything's quite stable again then at that point. But of course, then we have to try that cycle again of getting them extubated. And sometimes it can be successful if maybe we deal with some of the issues we didn't address first time round. But of course, if we're really struggling to get these patients extubated, that sometimes then is where temporary tracheostomy may need to fit in. And I'll talk about that in a second. One other little point to mention here in terms of recovery that's really neat with these patients is to use post-operative nebulization with epinephrine. So we know this is a very potent vasoconstrictor, and it can reduce laryngeal edema. So effectively, these little nebulizers can be purchased very widely online or in pharmacies and so on. They don't have to be anything particularly expensive. And the recommended dose is 0.3 milligrams of epinephrine diluted in 5 mils of saline. Put that into the vault within your nebulizer, and then you can nebulize the patient for about 10 minutes, and you can repeat that every 6 hours or so post-operatively. There are some higher doses, as you can see there, that have been published in the literature. And we can get some dose-dependent bronchodilation with the epinephrine as well. And this can be really useful, as you can see here in this little patient post-operatively. This patient's had a challenging recovery. We've managed to get her extubated, relatively stable, but you can see there's still a lot of abdominal effort there. You can't really hear it because of the nebulizer, but she's still making some noise. But this nebulization really helps in this situation. You can see the rhinoplasty there post-operatively. You can also use this if you're presented with a patient acutely, you know, in the sort of the heat stroke kind of acute crisis. This can work really well. So the temporary tracheostomy, I mean, if you go to the literature, it's reported in potentially being required up to 50% of patients after BOAS surgery in a number of different publications. I have to say that's not in line with my own personal experience. And I think certainly since the advent of the folding flap palatoplasty or that more aggressive staphylectomy, less patients need temporary tracheostomy in that post-operative period. But there are recent publications that show that it is an important adjunct in the management of, you know, patients after multi-level airway surgery. So here's one such patient that you can see has regurgitated, has some nasal reflux as a result of that, has had all that management there that we talked about, has been extubated, but really not doing very well at all. You can see the demeanor of this patient is completely changed. He's focused purely on the task of breathing at this point. You can see the grimacing of the lips there with each inspiration, the abdominal and diaphragmatic effort. And this is a patient we'd really worry about in this kind of situation. So in terms of doing a tracheostomy, I mean, very simple. In terms of the surgical treatment, you just need a basic surgical pack. A Gelpi retractor is very useful. And then we need temporary tracheostomy tubes. And the key thing is these are tubes that are uncuffed. So we don't need to have these tubes with cuffs in place because we want the patient to breathe around the tube as well as through it as the airway compromise starts to resolve. And we use some umbilical tape to secure these tubes in place. So these are just a series of little practical steps in terms of how we do this. So at the top here, we have the patient in dorsal recumbency. Bear in mind that the emergency cut down is a very rare kind of situation. These patients, when we deem the need of tracheostomy, we intubate them normally again, and generally that is possible. We can put them into dorsal recumbency. We can do an aseptic preparation of the site, and we can take our time to think about what we're doing. The red lines here denote the location of the cricoid cartilage, so the most caudal cartilage of the larynx. If we palpate that, we can feel a little step that drops down caudal to it onto the trachea. And we make our skin incision then through over the order of the 2nd to the 6th tracheal rings. So we bring that incision through the subcutaneous tissue, and it's very easy then to see the two so-called strap muscles of the neck, which are the sternohyoideus muscles. And then we use a scissor then to bluntly dissect between those two muscles down through that little median raphe. This is where the Gelpi retractor then can be quite useful to insert those and retract those sternohyoideus muscles laterally, and the trachea is immediately evident. Then we want to identify approximately the 3rd and 4th tracheal ring. It's not critical that it's the 3rd and 4th. It could be the 4th and 5th, or the 2nd and 3rd. The key thing is that it's nice and cranial. We can place a little stay suture around each ring, and by putting opposing traction on those, you can then make a little tracheotomy incision. That does two things. Number one, it helps you just open up that tracheotomy site to help you insert your tube. And now before placing in the tracheostomy tube, you'll need to back up your ET tube a little bit to be able to slot the tube in. And then it's a matter of simply just slotting that tube into position and then securing it with umbilical tape. The second function of these stay sutures are that we can actually tie a little knot in them and leave them there as a loop, so that should the tube become obstructed or dislodged, we can put some traction in those open up the tracheotomy wound, and the patient can actually breathe through that whilst we summons help and get another tracheostomy tube put in place. The final take-home point is that we want a tube that is approximately 50% of the tracheal diameter. Again, we want them to breathe around the tube, not just through it. And then the hard work starts. So placing the tube is easy, but managing it is much more difficult. And certainly there's been very high complication rates reported in BOAS patients with tract tubes postoperatively. Nearly all of them, there will be some degree of tube obstruction, coughing, potentially tube dislodgement, and so on. But most of them can be managed. Overall low mortality rate associated with it, and the overall success when used in this situation is still very good, but it requires really good nursing management, and that's something Shirley Bell is going to pick up on the next session, and she's got considerable experience in. You can see the same little patient here, literally 10 minutes after that tracheostomy tube was placed. You can see a completely different demeanor in this patient, and all of that abdominal effort and so on has dissipated. He's now just more interested in escaping from his bed. So really useful when they're needed. Ideally, we want to keep them in the shortest period of time as possible because that will reduce the complication rate. Okay, so I think we're just about on time. And I guess to wrap up, I guess the key take-home points that I would make from the session this evening are that I guess as responsible professionals working in the veterinary sector, I guess we have to acknowledge that brachycephalic dogs do have a range of breed-related health disorders. Of all of those, BOAS is probably the one that is having most of the clinical and welfare impact. And I guess we, as advocates of animal welfare and so on, should be cognizant of the clinical signs and do our best to raise awareness of this condition. As I say, hopefully if we were having this discussion again in 10 years' time, we might have a slightly different take on all of this. In terms of what we do right now, well, I guess I would encourage this functional assessment of any brachycephalic patient that potentially has airway issues. And certainly if they're in that sort of grade 2, grade 3 category, then I would really encourage early proactive assessment and intervention as required in those patients. And I definitely think I get better outcomes when I see these patients at 7, 8, 9 months of age, and we get in there and we can take away a lot of those primary congenital abnormalities before they have a lot of the secondary changes there. And that's really our aspiration. Of course, we can still benefit those patients that are older and potentially more severely compromised, but maybe not improving their overall clinical signs to the same degree. And of course, I'm very fond of these dogs, and I still think surgery here can be hugely beneficial for the individual animal. And these patients or pets are owned by a family, they're beloved pets and so on, and that pet is all that matters to them, not the sort of more sort of global issue with the breeds and so on. And surgery can really have a hugely beneficial effect in terms of improving that patient's symptoms and overall quality of life. And I guess to wrap it up, I mean, we'll just go back to our patient that we saw at the beginning there. Certainly one of the more extreme cases that I have treated. And here he is, literally the morning after surgeries. This is less than 24 hours later. It's one of our former interns talking. He's loving his life now, and hopefully that's the case. But you can hear that air is moving quite freely through that upper airway. There's none of that stertor that's audible now from a distance, and there's none of the abdominal effort that is there. And that is also true after he was exercised. So thank you very much for your attention. As I mentioned at the start, I'll play a very short little video clip here that will just give you a little behind the scenes peek at our hospital here and share with you, I guess, a little bit of our kind of values and our mission for the future. And then I'll be happy to take any questions that might have come up. So thank you for your attention.
Welcome to Northern Ireland Veterinary Specialists. My name is Aidan McAlinden.
And my name is Rob Adams, and together we're the clinical directors of Northern Ireland's first specialist-led multidisciplinary veterinary hospital.
We launched our hospital back in the autumn of 2019, and we're happy to receive referrals in soft tissue surgery, orthopaedic surgery, neurosurgery and cardiology. The hospital was purpose-built and has state-of-the-art facilities. We have 2 fantastic operating theatres, a CT scanner, arthroscopy, laparoscopy and a full cardiology suite, including echocardiography, ECG and the ability to perform interventional procedures.
What really sets us apart is the fantastic team that we have here. We've got board certified specialists in both cardiology and surgery, and we're supported by a truly experienced team of nurses and interns providing round-the-clock care to all of our patients.
Here at Northern Ireland Veterinary Specialists, we see ourselves as having 2 clients. One, the referring vet that sends us cases requiring specialist care, and secondly, the client and their beloved pet who seek out that treatment. We feel that communication is absolutely paramount to that treatment, and we keep both the referring vet and the client informed of treatment and outcomes at every step of the way.
We'd like you to see us as an extension of your team to be able to offer your clients more services and access to specialist care. We aim to make the referral process as simple, efficient and as user-friendly as possible. And we're always happy to talk on the phone about cases and look at images, x-rays, whatever you need.
We'd like to take this opportunity to pass on a very sincere thanks to all of the referring vets and their clients that have come to see us at Northern Ireland Veterinary Specialists. We look forward to a long relationship working with you in the future, and we hope to exceed your expectations at every step of the way. We thank you for choosing Northern Ireland Veterinary Specialists for all your referral needs.
So yes, thank you once again, both for your attention tonight and indeed, yes, your support since we launched our business almost a year ago now. I'll be very happy to take any questions now that come through at this point, Renee.
Hi, Aidan. Thank you very much for sharing your wisdom on this subject. We have a fair few questions coming through, so I can post them to you, or you can read them yourself by pressing the Q&A button. I'm going to start you off with the first one. Would a pre-medication require changing depending on the grade of BOAS plus minus laryngeal paralysis that the patient falls into?
So really good question. So I guess overall, the easy answer to that is not necessarily. I guess we would make the decisions in terms of pre-medication on a case-by-case basis, and that would be bespoke to the individual patient. But for most of these patients, other than their airway obstruction, they're often very healthy patients. So from that point of view, we would very often use drugs like very low dose acepromazine, maybe alongside something like methadone. And at the doses that we use methadone, often maybe 0.2 or 0.3 milligrams per kilogram, it doesn't cause any respiratory compromise. And we'd be very happy to use that whether a patient is grade 1 or grade 3. Of course, we get patients that come in and they're brachycephalics with severe airway compromise that are also really aggressive, and we have to add in maybe other more potent pre-medicants like a little bit of low-dose metatomidine, for example, or dexmedetomidine. But ultimately, it's a case-by-case basis decision. But generally speaking, the severity of the airway changes doesn't necessarily change the pre-medication.
Thank you.
Hopefully that answers that.
I think so. Second question. We are currently giving maropitant to brachy's post-op to prevent regurgitation and nausea. Is there any studies proving the effectiveness of this?
Yes, absolutely. There's really good evidence behind this. So certainly using antiemetics, and also I see the next question coming in is kind of linked to this a little bit as well, in terms of, do we routinely use omeprazole at the time of induction? And the two often go together. We would pre-medicate with omeprazole in all of these patients, and typically follow that for a minimum of 8 weeks post-operatively. That's something that came from that study that I mentioned about the medical treatment concurrently with the upper airway surgery, and those patients in that French study indeed did have omeprazole, and that's been well documented. That's something definitely we'll be picking up again in a lot more detail in the next webinar in the series. I deliberately skipped over, I guess, some of the pre-anesthetic management of these patients and so on, because I don't want to steal Shirley's thunder for next month. So she will speak quite a lot about the pre-medication handling of these patients around the time of induction, and also on the recovery.
Excellent. Next questions. When a dog continues to regurgitate months after BOAS surgery, but it's less often than prior to surgery, do you recommend any long-term antiemetics, or when should this disappear over time?
Yeah, so another really good question. So as we alluded to earlier on, that in those patients with mild gastrointestinal signs, there often is an improvement in those symptoms seen with airway surgery alone. But if we're not seeing that improvement after several months, I guess that really would indicate that further investigation of what the underlying cause of that upper gastrointestinal signs actually are. So I'd quite like to then, in that patient, work them up by way of having things like, we do typically some full blood panel there, we do upper GI endoscopy, potentially some biopsies of the stomach, and absolutely have targeted treatment. That patient could have a mechanical issue there, like an esophageal deviation, for example, or a hiatal hernia, and may well be a surgical candidate based on that. And there are a few situations where we actually see patients present for BOAS, but actually their gastrointestinal signs are more severe than their respiratory signs, and we actually prioritize it the opposite way around, where we investigate and treat that first, albeit that is much less common.
Thank you. Next question. Do you prepare the surgical incision sites with anything?
Yes, so all the surgical sites in terms of the oral cavity and the nares would be prepared with povidone iodine, so it's well tolerated by mucosal surfaces. So effectively that would be painted onto the mucosal surface and along the incision lines within the oral cavity and the nasal planum prior to surgery.
Thank you. Last question, unless people want to submit more, but at the moment, that's the last question. Aidan, do you need to clamp the soft palate prior to cutting when you perform the staphylectomy?
So that's a great question, Dan. No, you don't need to do that. So effectively, my technique for the staphylectomy would be I would place effectively a suture on either side at the level of the caudal fornix of the tonsil. And then I would use very nice, fine, curved Metzenbaum scissors. And by applying a little bit of tension with forceps to the caudal edge of the palate, I then make very careful millimeter by millimeter little cuts with the scissor. As you start to do that and close the blades of the scissor very gently, you will identify then branches of the palatine vessels. And I use bipolar cautery then for pinpoint ligation, or sorry, hemostasis of those vessels as I go. So it'll be a combination of cut a couple of millimeters, cauterize, cut a couple of millimeters, cauterize, until we go all the way across. Here at the hospital, we've also got the ability, we've vessel sealant devices such as ligature, and we can actually use those to effectively clamp and obliterate the palate tissue as well. And that's something that's well tolerated in these patients. They just need to be big enough to allow that instrument to be actually manipulated within the oropharynx. So I don't routinely clamp, and I did at the very start when I started doing staphylectomies, but I think it leads to more postoperative edema and swelling. But I appreciate that might be necessary if you don't have access to bipolar electrocautery, for example. But I think that's an important thing to have some form of electrosurgery available to you when you're taking on these cases.
Excellent. Thank you very much. I think that was the last question. So thank you again, Aidan, for sharing your expertise with us, and thank you all for joining us. Next week's webinar is going to be an afternoon one about head and neck surgery in dogs and cats by Aidan's colleague. So hopefully we see you back next week, same day, but 1 o'clock rather than in the evening. And with that, I wish you a very pleasant evening and a nice rest of the week. Bye-bye.